So in the WHO 2021, the circumscribed astrocytic gliomas have been classified as under the six entities: the pilocytic astrocytoma, the high-grade astrocytoma with piloid features, pleomorphic xanthoastrocytoma, subependymal giant cell astrocytoma, chordate gliomas, and the astroblastoma MN1 altered. So a disclaimer that most of the slides, the material I have taken is from the WHO 2021, because that is the best place where you find the actual information. And a lot of research, I mean, years of research has gone into making the WHO 2021. So my pathologist colleague would find it a repetition, but it's always better, revising and re-revising is required, more so with the CNS tumors, because a lot of things, you have to really read in between the lines to really understand all the molecular alterations which have happened over the years. I think ma'am will agree with me. On this.
Yes.
So I'm audible now, ma'am?
Yes,
as it is, I'm loud. So.
No, it's okay. Very clear.
Okay, ma'am. So, this is the tabulated form of these 6 tumors which I just said, and these are the grades which are assigned by the WHO through these tumors. Like the pilocytic astrocytoma is always grade 1, and the characteristic molecular genetic alteration, which I'll be talking little in details, is the Kia1549 BRAF fusion and the BRAF mutations. So few of the terms will I'll be repeating again and again, so that they are imbibed and they are ingrained, because even we as neuropathologists or as pathologists routinely using it, still we forget the names and confuse. So the second is the high-grade astrocytoma with piloid features, and this is the grade is not assigned, but usually it is either usually I think it is taken as grade 4. The PXA, it can either be grade 2 or grade 3. The subependymal giant cell astrocytoma SEGA is grade 1, and the molecular genetic alteration is the tuberous sclerosis TSC1 and TSC2. The chordate gliomas of the third ventricle, they are grade 2, and the astroblastoma, which is now MN1 altered, is not graded as of now, but usually they can be low grade and high grade, but most of them they are high grade. So coming first to the pilocytic astrocytoma, it is one of the commonest tumors in the pediatric and young adults. But though it is the commonest tumor a pathologist or a neuropathologist sees in their lifetime, but it can masquerade as various CNS tumors, and one can falter, especially in pilocytic, and even I have recently faltered on one pilocytic astrocytoma because of the morphology. So, but the classical definition for a pilocytic astrocytoma, they are bipolar cells. They are compact, or they can be in loose architecture. And the characteristic feature is the Rosenthal fibers, which we all have learned throughout MBBS and in our PG, etc. And the eosinophilic granular bodies, or the EGBs. The pilocytic astrocytomas are associated with the MAP pathway gene alteration, the commonest being the Kia1549. And this is grade 1, as we have already seen. So they can, I'm laying emphasis a little bit on morphology also, because I think few pathologists are also there in the group. Though I know mostly it is for the clinical and the radiation oncologists. So there is a biphasic pattern where you see the compact areas, and the compact area will have a piloid cells with abundant Rosenthal fibers. And the other pattern is the dispersed pattern, where the cells look like an oligodendrocyte. The pattern sometimes can be can point to that whether it is a biphasic pattern, it is seen in cerebellar tumors, or a compact pattern usually seen in adults. And the oligodendrocyte-like pattern may be associated with the FGFR1 alterations. Normally, all the pilocytic astrocytomas, they are very richly vascular. The vasculature can be in the form of thin vessels, or imparting a cystic architecture to the vessels, or they can be thick hyalinized. So this thick hyalinized vessels is the commonest feature usually we'll find in all our reports. But glomerular microvascular proliferations as seen in GBMs can be seen in pilocytic astrocytomas, and one should not mistake it for a higher grade tumor. Infarct-like necrosis is seen, but palisading necrosis is a no. You never see palisading necrosis in a grade 1 pilocytic astrocytoma. Leptomeningeal involvement causing an extensive desmoplastic reaction is seen with pilocytic astrocytomas. So this is the common morphology which we see. This is I just said that it is a biphasic tumor. So this is one pattern of the tumor, and adjacent you see a lot of piloid cells, and the cells are placed very discreetly. So because of this filaments of the tumor cells, this is the vasculature which is imparting a cystic architecture. Now these are the classical Rosenthal fibers, and these are the eosinophilic granular bodies as described in our reports. You must have heard of penny on a plate morphology. So basically what happens, these are tumor giant cells where the cells are stacked on in the periphery of the cell. The nucleus is stacked on the periphery of the cell. This is the oligodendrocyte-like pattern of a pilocytic astrocytoma. But when you have the morphology like this, nobody can mistake. So normally a pathologist will not mistake with this and this. But still, there are tumors which mimic this kind of morphology, and I'll be subsequently taking that tumor. So pilocytic astrocytomas, they usually have, most of the tumors, they have the MAP pathway alteration in one form or the other. And this is the pie chart to just show the various MAP kinase, MAP pathway alterations in the cerebellum, the diencephalon, and the cerebellum. And these are the various alterations, the PTP and 11, the NF1, the BRAF. I'll be taking it details in the next slide. So this is the table from WHO itself, and these are the various mutations which you see in pilocytic astrocytomas. Needless to say, these are all exclusive of each other. So if you have a Kia1549 fusion in one of the tumors, you will not have the BRAF mutation in that tumor. And the other mutations are the NF1 mutation, which is seen usually in the pilocytic astrocytomas of the optic nerve, and the FGFR mutations or fusions, and the NTRK family fusions. So the pilocytic astrocytomas, the RAS-BRAF ERK signaling seems to play a central role, and the oncogenic BRAF fusions and the BRAF V600E missense mutations are the most prevalent, and they are targetable. NF loss and the BRAF fusion activation, they both lead to mTOR activation, but this is through different routes. And the pairing of MAP kinase pathway inhibitors with mTOR pathway inhibitors is being targeted in a lot of clinical trials. So this is the commonest mutation, that is the fusion of the Kia BRAF and the upper black box here. It is showing that even I have to read because from my notes to explain. Actually, so the upper black box, it represents 7q34 on the long arm of chromosome 7, and both Kia1549 and the BRAF, they read towards the centromere. And a fragment of approximately 2 megabase is duplicated, and it is reinserted at the breakpoint, producing a tandem duplication and fusion between the 5 end of the Kia1549 and the 3 end of the BRAF mutation. So this is a normal cell where you see one green signal, one red signal, again green signal and red signal. But when there is a fusion, so there is a yellow signal. So red and green fusion is seen, and this is a yellow signal which signifies the Kia-BRAF fusion. Now coming to the Pilomyxoid astrocytoma, most of the circumscribed gliomas, they happen in either children or young adults, but Pilomyxoid usually happens in infancy. And the location is hypothalamic or chiasmatic, and there is higher rate of recurrence and poor outcome vis-a-vis pilocytic astrocytoma. as it shows propensity for CSF dissemination. So the cells, they are piloid, and there is a myxoid background, and the cells are arranged around the vessels. They appear to be emanating from the vessels, and this is called the angiocentric arrangement in our reports. There are no Rosenthal fibers or EGVs in the Pilomyxoid astrocytoma, and rare hybrid tumors have been described, and their biological behavior is poorly defined. And the Pilomyxoid astrocytoma also follow the MAP kinase pathway, as seen in the pilocytic astrocytomas. Now, coming to the second tumor, which has been described in this WHO, though there have been many articles before, but this was not in the previous WHO. So this is high-grade astrocytoma with piloid features. So it is defined as an astrocytoma, often with high-grade piloid or a GBM-like histological features, and there are alterations of the MAP kinase pathway genes combined with homozygous deletion, which involves the CDKN2A or 2B locus and or ATRX mutation. So normally what will happen if you are thinking, a pathologist thinking whether it is this or that, your ATRX will help you. If there is loss of nuclear staining, then you know you are dealing with an astrocytoma, and it is not a pilocytic astrocytoma, it's a higher grade astrocytoma. So that is how you can start thinking on that. Then this was this article by the study by Kapper et al., and where they identified 83 of the tumors of their study, which they had a CDKN2AB, which I described, and the outcome analysis was unfavorable clinical course in comparison to the pilocytic astrocytomas. So these are cellular and moderately pleomorphic gliomas, and they have piloid or hair-like cytomelastoid processes, and they will have EGBs and Rosenthal fibers, and but necrosis can or cannot be seen. But mostly, if you get a good tumor tissue, then you will see the piloid as well as the GBM-like features. It is unlikely that you will just see pilocytic-like cytoma-like feature and not see the higher grade. So usually you should see both the features, and this is how it looks. This area looks like a pilocytic astrocytoma, but there are areas which classically look like either a PXA, that is the pleomorphic xanthoastrocytoma, or GBM-like areas are seen, like the pleomorphic cells are there. And this IHC stain is showing loss of ATRX in the tumor cells. So this is one indicator that it is not a pilocytic and you are dealing with a higher grade tumor. The third tumor under this entity is the subependymal giant cell astrocytoma. Now, these are periventricular tumors which are composed partly of large ganglion-like astrocytes, and they are strongly associated with tuberous sclerosis, and they are WHO grade 1. So they arise from the subependymal tissue of the lateral ventricles, the foramen of Monro. They are solid, partially calcified masses, and this is the most commonest CNS neoplasm in tuberous sclerosis. The incidence rate of SEGA among the patients with tuberous sclerosis is 5 to 15%, and the tumor is one of the major diagnostic criteria for tuberous sclerosis. Now, they show evidence of biallelic inactivation of TSC1 or TSC2, and with the second hit frequently observed in deletion or loss of heterozygosity, and leading to loss or reduced tuberin or the hamartin. These are the proteins. So this is just to reiterate it again. And they act through the mTOR pathway. So mTOR inhibitors can be used to treat tumors of the tuberous sclerosis as well as SEGA. So these are the other tumors, and which I think all the clinician, everybody is aware of, because this used to be the very hot question for all the exams. So like I said, they are circumscribed and they can be moderately cellular. The cells are polygonal and with abundant glassy cytoplasm, or they can even be spindled and they can be like gemestrocytes. And there is considerable nuclear pleomorphism and multinucleated cells can be seen. And the parenchymal or vascular calcification are frequently seen. The presence of mitosis, vascular proliferation, or necrosis does not indicate anaplastic progression in a SEGA. So this is how a SEGA looks. This is a classical tumor cell with abundant cytoplasm and which is very pink, glassy, and peripherally located nuclei. The cells, because of the stroma, can be stretched or spindled. And this is to show this IHC is for S100, so they are strongly S100 positive. GFAP can be variable in these tumor cells. So the prognosis for SEGA is usually favorable if there is complete gross resection, but sometimes the tumor is not amenable to complete resection or not amenable to surgery. So these tumors or the patients tend to have greater morbidity, and inhibition of mTOR with everolimus has been used for control of SEGA progression and for reducing the tumor size or in SEGA. Now I'm coming to chordoid gliomas. This is the fourth tumor type. So initially they were called chordoid gliomas of the third ventricle. Now WHO has removed such things like the third ventricle and few other things which ma'am has already covered in her 2 lectures. So this occurs only in third ventricle and in the anterior portion. And the origin is in the region of the lamina terminalis in the ventral wall of the third ventricle. And this tumor is seen in adults and the median age being 45 years. These are solid neoplasm, and they are seen in clusters and cords of epithelioid cells. And the tumor can either have a solid pattern with sheets of polygonal cells or a fusiform. Fusiform meaning spindle-like pattern with the spindle-shaped cells, or a fibrosing pattern where you see a lot of collagenization. And the adjacent brain parenchyma will show reactive astrocytes, Rosenthal fibres, and chronic inflammation as seen in this pictogram. So this, for the non-pathologist, so this is a circumscribed tumor, meaning it is not infiltrating into the adjacent tissue, and it has a very nice lymphocytic response, or kind of inhibiting it from infiltrating into the glial tissue. The tumor per se, the cells are either polygonal or epithelioid or spindled, and the stroma which is supporting the tumor is myxoid. So the cells appear to be discretely placed, and this is GFAP positivity in the tumor cells, and the tumor cells are positive very strongly for CD34. Now, one thing which is remarkable about the chordoid glioma is that they can be TTF1 positive. So one has to remember that some brain tumor, if you're, by the way, if you're suspecting a metastasis also, because in our center, we get more of metastasis than primary brain tumors, and you have a TTF1 positivity. So one has to be wary of this, that this particular tumor is TTF1 positive. So the mutation which is described in the chordoid gliomas is P463H PRKCA gene. It is ubiquitous in the chordoid gliomas, that is, it is not seen in any other tumors of the body, neither CNS or any other tumor of the body. And this is a novel missense mutation affecting the codon 463 of the PRKCA gene. Now, this gene encodes the catalytic alpha subunit of the PKC in intracellular signaling downstream of multiple transmembrane receptors, and the mutation results in the substitution of histidine for aspartate at the codon 463 within the active site of the kinase domain. So the this is just to reiterate the same. The cluster at a single mutational hotspot within the active site of the kinase domain in the encoded PKC alpha protein. It is strongly suggestive that these are oncogenic and gain of function mutation. So they result in increased MAP kinase pathway activation and lead to high levels of phosphorylated ERK. And this may render the chordoid glioma sensitive to the MEK inhibitors. Now, coming to the fifth tumor type, there are total 6. So this is the fifth tumor type. I have kept the Pilomyxoid astrocytoma for the last because it's a it's actually a huge book in itself. So astroblastoma MN1 altered. Initially, it was just called astroblastoma. Then they found this specific mutation in astroblastoma. So it is also a circumscribed tumor with MN1 alteration, and it is composed of round cells. And so all the cells are round, epithelioid, etc. But the tumor usually has either a pseudo-papillary pattern or a papillary pattern. and they are perivascularly arranged. So this picture again shows a tumor which is circumscribed. Okay, so this occurs predominantly in the cerebral hemispheres, usually in the parietal frontal region, and there is a striking female predominance. That is, at least 90% of the patients will be females. And on MRI, these astroblastomas are well demarcated, solid or cystic masses, and they are isointense or hyperintense on T1 and hyperintense on T2. So these are the morphological pictures of the astroblastoma. So this is a vessel, and these cells are emanating from the vessel, and they have abundant cytoplasm, unlike the Pilomyxoid astrocytoma, where I showed the cells had very thin cytoplasmic projections. And this is a pseudo-papillary pattern, as I just said. The cells have abundant eosinophilic or glassy cytoplasm. Sometimes the vessels will be so hyalinized, or the stroma will be so desmoplastic that the cells will be compressed, and one would think of it as a round, malignant round cell tumor. And they can either be in the pseudo-rosette or a pseudo-papillary configuration. I think we can skip this. And the tumor cells can be round, rhabdoid, or spindle. And vascular and stromal sclerosis is sometimes so prominent that the cells are compressed and they give a round cell appearance to the tumor. So what is MN1 rearrangement, which we are talking about in astroblastoma? So MN1 rearrangement, along with the fusion partner genes, which is commonly BEND2, or sometimes it can be CXX, C5. They drive the genetic alterations of the astroblastomas, and there are structural rearrangements of MN1 gene at the chromosome band 22q12.1. So there is chromothripsis of the X chromosome. It may be involved in the formation of this MN1 BEND2 fusion gene. MN1 fusions, they occur in as many as 70% of the astroblastomas, and more than 60% of MN1 fusion positive CNS tumors are astroblastoma morphology. Why they said this? Because some of the tumors are high grade, the PNETs of the CNS. And the different fish patterns may exist in MN1 rearrangement, as can be seen in this picture. Now coming to the PXA, that is pleomorphic xanthoastrocytoma, and it is called pleomorphic xanthoastrocytoma. First of all, the tumor cells are very pleomorphic. They are varied in appearance and in size. And xantho means xanthoma cells, or cells which have lipidized or foamy cytoplasm. So that is why it is called a pleomorphic xanthoastrocytoma. Astrocytoma with large pleomorphic cells, and they can be spindled and lipidized cells, and they have characteristically BRAF V600E mutation and other MAP kinase alterations as well, plus homozygous CDKN2AB deletion can be seen, and usually they are grade 2 or they can be grade 3. So it is a tumor which has superficial in location. So normally whenever you will get a PXA, if you elicit the history from the patient or you check the file, usually the patient will present with epilepsy because it's a very superficial tumor, sometimes attached, just very close to the meninges. So majority they occur supratentorally, and that too in the temporal lobe. And many patients, they present with long history of seizures, like I just said. And PXA can be encountered in patients with NF1 and in rare cases with these syndromes like the DiGeorge syndrome, etc., and the Down syndrome. So in the grade 2 tumors, you have the spindled epithelioid cells and multinucleated cells, and intranuclear pseudo-inclusions are seen, the nucleoli are prominent, and granular bodies can be seen. And there is a special stain in histo which we use, which is called reticulin stain. So that outlines each and every cells in a PXA. So it is a very helpful stain if you don't have IHC. In WHO grade 3 tumors, there is less of pleomorphism and a more diffusely infiltrative pattern. And anaplasia, it manifests as brisk mitotic activity, and necrosis can be seen. The cytological patterns of anaplasia, which can be seen in WHO grade 3 PXA, are either the small cell type, the fibrillary, epithelioid, or rhabdoid type. So this is a classical PXA, the pleomorphic xanthoastrocytoma grade 2. Here, it's a very busy tumor. You see a lot of cells which are multinucleated or uninucleate. And this is if you can see at this resolution, this is an intranuclear inclusion. And there are admixed these small cells which are lymphocytes. So this circle highlights the cells which have foamy or granular cytoplasm, and this is an intranuclear inclusion which I was just talking about. The other type is the tumor can sometimes be spindle. So you can mistake it for a meningioma because it's so spindle. And on higher power, you'll see these eosinophilic granular bodies. So one can make out that probably it is a PXA or some other tumor. And this star is showing a classical lipidized cell of a PXA. So the IHC, it is positive for GFAP, S100, and BRAF by IHC is very strongly positive. It is granular and strong, like seen in this picture. And they are also positive for synaptophysin. Now, the morphology of PXA grade 3, the tumor can be pleomorphic, or they can resemble a glioblastoma, or it can, even look like here, it looks like an astroblastoma or some other tumor. So you will see frequent mitosis in the tumor. Like we discussed, that they can be either fibrillary or they can be epithelioid or rhabdoid, because here the cell has a tummy and it has some material in it. So this is a rhabdoid cell for a pathologist. And this is the small cell variant where the cells are uniform, round, and they look like a malignant round cell tumor, as we say in layman terms. So PXA either have MAP kinase pathway alterations or they have CDKN2AB. They can coexist. It's not that they are exclusive of each other. So essentially, all the PXAs, they harbor genetic alterations in the MAP kinase pathway, causing aberrant activation of this pathway. And the most frequent being BRAF V600E, which is seen in 60% of the cases. The other mutations are in the NTRK1, 2, and 3, or RAF and NF1. And the CDKN2AB homozygous deletion, as many as 94% of the PXAs harbor alterations of the CDKN2AB, which is a homozygous deletion, and the combination of a BRAF V600E mutation and CDKN2AB deletion always points towards mostly points towards a PXA. So there are many clinical trials and regarding the treatment of gliomas by BRAF inhibitors, and more so for the PXAs. And this is one study, the B basket study, and where they said that they've concluded that BRAF V600E is a targetable oncogene, and particularly in the PXA subgroup. And additional evaluation is needed to clarify the precise use of RAF and MEK inhibitors alone or in combination in patients with primary brain tumors. And then they again said that vemurafenib, particularly in PXA, can be clinically meaningful. So prognosis, frequently it recurs and is associated with decreased survival compared to the other circumscribed gliomas. And the malignant progression is more common in PXA than in the other RAS MAP kinase driven CNS gliomas, like a pilocytic astrocytoma. And upon progression, survival is markedly reduced, and even with currently available therapies. So the extent of resection is the most significant prognostic factor associated with recurrence. And the CNS WHO grade 3 PXA should be managed with additional therapy, that is radiotherapy. So should I take questions or should I just take my cases? I don't have many, but I would. Ma'am, can you unmute?
Yeah. Let me just see. There are no questions on the screen, and there are
either I did not communicate anything. Any case, I will just take the case.
I think the question will come. Can you just continue with your cases?
That's okay, ma'am. That's okay. Yeah. No, because I thought even if the questions come, I will have to take your help to answer.
Yeah, we will.
I just actually we don't have many cases, but pilocytic astrocytoma, like I said, usually everybody has a lot of cases. So pilocytic we had enough, but the other cases we didn't have. Only PXA we have. So I'll just show few cases that actually we are doing some neuropathology. So this is a 14-year-old female with a cerebellar hemispheric tumor, which was a cystic lesion, and there was no diffusion, restriction, blooming, etc. So this is again a classical pilocytic where with lots of hyalinization around the vessels, and it's a pink tumor. These are the eosinophilic bodies. The tumor had a predominance of the Rosenthal fibers and the EGBs. And these are the pretty looking Rosenthal fibers. I mean, I think in this slide we had more than we've seen in the book put together. And this is again the Rosenthal fibers. The increased vasculature. These are in linear pattern or they form chains. So this is classical of a pilocytic astrocytoma.
This is called as the garland pattern, and this is very characteristic of pilocytic astrocytoma.
Yeah. Okay. So this was a pilocytic. Again, I have 3 cases of pilocytic just to reinforce that what all is seen. In spite of seeing so many pilocytics, still sometimes they can cause problems. So this is again a pink tumor, and these are the EGBs. And okay, so in this case we did a SOC scan. So it is little weak, free come, but it is SOC scan positive. ATRX is retained. So compared to if you are in doubt whether you are dealing with a low-grade astrocytoma or a pilocytic, ATRX can be of help because ATRX is always retained in pilocytic astrocytomas. KI is very low; it is just 1 to 2%. Okay, so this is also pilocytic, and this is another case. Which is a tumor which was in periventricular region, and if you read the radiology, it looks as if it is a very high-grade tumor. It's going everywhere it seems. But when you see the morphology, this is actually what is a pilocyte or a cell which has hair-like processes. So I think ma'am will agree here. This is showing nice, and these are cells where the cells are little compact and around the vessels. This is the EGBs, and these are the Rosenthal fibers. They are carrot red in color usually. Same. And these are the concentric vessels. P53 is also very low in pilocytic. Usually it is not seen. ATRX is retained. KI is just 1 to 2% again. So this was also a pilocytic astrocytoma. Now this last case is a PXA, grade 3. So this is a 40-year-old male who had a large, irregular, diffusely infiltrating, space-occupying lesion in the left occipitoparietal lobe, and there was a large amount of surrounding edema. So the tumor had a spindled morphology, but the cells still had abundant cytoplasm because it is looking pink to the pathologist, and this is microvascular proliferation here. And the cells, here the cells are more pleomorphic. There they were looking monomorphic, spindled, and in one pattern. Here they are more pleomorphic, and some are multinucleated. And these small cells are there. These are the lymphocytes which are admixed with the tumor. And here again, a vessel is proliferating, and this is the cell with the abundant cytoplasm. And this was another area in the same tumor where the cells were very busy. A lot of mitosis and apoptosis and karyorrhexis was seen, along with necrosis in the bottom of the screen, if you see. So the tumor was focally positive for synaptophysin, but this tumor did not express BRAF V600D on IHC. It was strong positive for CD34. This is the Ki67, which is very high, as can be compared with the pilocytic astrocytoma which we saw. So this was a pleomorphic xanthoastrocytoma, CNS WHO grade 3. So this, with this, I would like to thank you for your patience, and if any questions are there, or maybe later we can